Today I will talk about, or we continue with the large and small airways disease lectures. In the first lecture, I was talking about mainly the trachea and the main bronchi, and today I will speak about the small airway. And we will start with the bronchiectasis, and we can define a bronchiectasis as an irreversible chronic dilatation of the airway. And this is very important, it's irreversible. Morphologically speaking, we can divide into three different types. The less involvement is called cylindric bronchiectasis, and it's a minimal dilatation of the airway. Then we have the varicose bronchiectasis, where you see a cystic lesion plus a narrowing. So you will see cystic narrowing, like a string of pearls. And finally, we have the cystic, that could be multiple cystic lesions, mainly in the lower lungs, but can be seen in anywhere. So about the pathogenesis, it's very important because many theories have been postulated to explain whether the leading cause is congenital or acquired. And probably the majority of the authorities are subscribing to this vicious circle theory that is explaining why we can develop, or we can see a development of bronchiectasis. For sure, there is a microbial insult in the airways, and sometimes we have some susceptibility of the genetic susceptibility of the host, and this is causing a tissue damage in the airways. And because of that, we have a destruction of the muscular and elastic components of the bronchial wall, and this is producing some defective in the mucociliary clearance. Because of that, we have the microbes persisting in the bronchi longer, and this favoring the colonization of the microbes within the airways, and this is producing a chronic inflammation, and the chronic inflammation is causing more damage and progressive lung change. And you have the vicious circle that is the most commonly or most accepted explanation about the origin of the bronchiectasis. Bronchiectasis was seen initially in 1819, but was read in 1950, who described more in detail the origin and the type of bronchiectasis. When we are seeing bronchiectasis, this could be localized, like in cases of TB, or could be more diffuse and extending into the upper and lower lungs, and this is typically seen in cystic fibrosis. But bronchiectasis is not a disease, it's a sign or it's a finding. So bronchiectasis can be associated with many causes. Actually, could be post-infectious, could be secondary to an obstruction, could be secondary to a resection after a transplantation, could be seen in cases of mucociliary clearance impairment, like Kartagener Syndrome or primary ciliary dyskinesia, can be seen in cases of rheumatoid arthritis or collagen vascular disease, can be seen in congenital causes like Immunocoum or Williams-Campbell. We can see bronchiectasis in ABPA. So this is not a diagnosis. We are seeing bronchiectasis, and we have to see what is the cause of the bronchiectasis. The most important thing is to know how to recognize bronchiectasis in the chest radiograph. And normally, you can see like a multiple thin wall cystic lesion, mainly in the perihilar region, or you can see the tram lines in cylindric bronchiectasis, mainly in the upper lungs. Because there is sometimes chronic changes, there will be some scarring and loss of volume in the area where you can see bronchiectasis. Today, to do the diagnosis of bronchiectasis, we are using high-resolution CT. That is the typical or the method of choice to make the diagnosis of the finding in this case. In normal condition, the bronchus and the vessel have the same size. So when you are seeing that the bronchus is greater than the vessel and the ratio is more than 1.5, you can assure that there is an bronchiectasis. Also, you can see the signal ring sign, that is the dilatation of the bronchus with the pulmonary artery that is adjacent. If you have cystic bronchiectasis, you can see a cluster of grapes, mainly in the lower lungs. This is very important, no temporary airways. So when you are seeing that in the subpleural area, the bronchioles or the bronchi are seen that are dilated, and this could be called bronchiectasis or bronchiectasis, depending how peripheral is the abnormality. Indirect signs or findings, you will see thickening of the bronchial walls, or you can see the mosaic perfusion that I will show you in different cases. And here we have the three different types: the cylindric bronchiectasis, that is the initial involvement. Then we have the varicose bronchiectasis, where you see narrowing, dilatation, and narrowing, dilatation. And finally, we have cystic bronchiectasis, in this case in both lower lobes, in this case with a air fluid level in one of the cystic lesions. Two different types of bronchiectasis: more localized in a cases of a chronic infectious process secondary to a TB. In this case, you can see the tram lines in the upper portion of the right upper lobe, and you can see here a more diffuse involvement of the lungs, mainly in the perihilar region, in this patient with a subcutaneous pore, because the patient has a cystic fibrosis. As I told you, in normal cases, when we are checking the high resolution, the bronchus and the artery, pulmonary artery, have the same size. When we have that one of the bronchus or bronchi are more dilated than the vessel, the pulmonary artery, we can call that bronchiectasis. Here we have a typical appearance of the signal ring sign, and you can see the ring, that is the bronchiectasis, and the signet is the pulmonary artery that is close to the cystic lesion. We can see branching opacity because there is a occupation of the bronchiectasis by secretion, so we have mucus plug, we have thickening of the wall, we can see a cystic changes in the lung basis in cases of cystic bronchiectasis, or you can see bronchiolectasis, that is the dilatation in the very subpleural area that normally you can see that the bronchi are not seen in this area. So when you are seeing bronchi or airway in the peripheral portion of the lungs, that is totally abnormal. We can see again bronchial thickening. We can see multiple mucus plug in this patient with cystic fibrosis, and this is an indirect finding, that is mosaic perfusion. You can see areas with a lucency representing air trapping disease. Okay, let me talk about certain diseases that are associated with bronchiectasis, and one of the most typical disease is cystic fibrosis. Normally, this is seen in younger people, Caucasians. Actually, there are approximately 70,000 people suffering from this disease worldwide, and 30,000 people are living here in the United States. We have approximately 1,000 new cases per year, and the diagnosis is by age of 2. So this is very typical seen in very young people, and is characterized by the presence of a very thick mucus that is obliterating the bronchus, producing bronchiectasis and infectious. And because of that, we have a chronic or recurrent pneumonia or infectious process in the airways. When we have an infectious process, probably we have 2 or 3 germs that are very typically seen: Haemophilus, Staph, and Pseudomonas. Respect to the clinical findings, wheezing, cough, and sputum, because there is involvement of the pancreas, some patients can have pancreatitis and also cirrhosis. Respect to the radiological finding, you can see bronchiectasis anywhere, but most typically are seen in the upper lobes. So this is the typical appearance in the upper lobes, and the lower lobes less involved than the upper lobes. The prognosis is very poor, and many people die, and the only option to treat this patient could be transplant. Let me to show you some example. Here we have a patient, a young patient, 18 years old, with bronchiectasis in the perihilar region, mainly in the upper lobes. Look that the lower lungs are less involved, and in the abdomen you can see that there is a replacement of the pancreatic tissue by fat. In this other case, we have a patient with a more diffuse dilatation of the bronchi with some opacities, nodular opacity. This may represent mucus plaque within the airways. And this is the typical evolution, worsening of the opacities or new infectious processes. So when you are seeing this disease, please try to check the previous exam to see if there is some new infectious process.
And the big highlight, usually due to pulmonary hypertension.
This is something that can be seen in many diseases involving the bronchi. So when you have multiple bronchiectasis, there is some prominent hilar regions because there is a transient pulmonary artery hypertension or a permanent pulmonary artery hypertension. That is correct. This is another case with a history of cystic fibrosis, and you can see involvement of the lungs, left, greater than right. And here we have the same patient after transplantation. So this could be the solution, but unfortunately this patient 2 years later to this film had a new episode of cystic bronchiectasis, and you can see in the new study multiple bronchiectasis involving the both lungs. So this is not a definite solution, but could be one of the treatment possible in this disease. Other disease that is associated with bronchiectasis is Kartagener Syndrome. That is a subset of a primary ciliary dyskinesia. And what is the problem here? That there is an abnormal structure and function of the cilia. And because of that, there is an impairment of the clearing of the secretion. Okay? 50% of the patients with primary ciliary dyskinesias are Kartagener syndrome, that is associated with a triad: bronchiectasis, situs inversus, and sinusitis. So if we see a patient with bronchiectasis and there is a dextrocardia, you can suppose that probably there is a Kartagener syndrome. Imaging, you can see diffuse bronchiectasis, hyperinflation because of the bronchiectasis, prominent hilar region because of the dilatation of the pulmonary arteries, and the situs inversus. Here, in this case, we have multiple bronchiectasis in the lung basis, left, greater than right, and you can see that there is a dextrocardia. So because of this situs inversus, you can think that there is a Kartagener syndrome. Williams-Campbell Syndrome is another disease that is seen in younger people, very young people. And what is the problem? The problem is that there is a deficiency in the cartilage of the subsegmental bronchi, where 4th to 6th generation. So in the hilar region, I'm sorry, any question? If you see this patient, you will see that the hilar regions are totally normal, the periphery of the lungs are totally normal, and in the mid lung you have the bronchiectasis. This is seen mainly in infant or children, and during if you perform a CT on expiratory film, you can see that there is a bronchial collapse and there is air trapping. This is more distally. Here we have a typical case of Williams-Campbell syndrome. You can see that the hilar region are less involved as well as the periphery, and you can see that in the midfields you have the majority of the bronchiectasis. ABPA is another disease that is associated with bronchiectasis, and this is a hypersensitivity reaction to Aspergillosis fumigatus. And actually, this is seen or is associated with patients with asthma and cystic fibrosis. What is happening in ABPA? There are two different allergic reactions. We have type 1 reaction, that is a secretion or release of IgE and IgG with bronchoconstriction, and there is a type 3 allergic reaction with the presence of immune complexes that are deposited in the bronchial mucosa producing necrosis inflammation, and bronchiectasis. Respect to the clinical finding, similar to the other causes or other diseases, wheezing, cough, fever, pneumonia because of the super infection, and in the CT and MRI, CT and chest X-ray, you can see that there are bronchiectasis mainly in the perihilar region or in the upper lungs. One of the signs that you can see in this disease is the fingers in glove sign, that is bronchiectasis in the perihilar region with mucus plaque. And on the CT, it's very typical to see three-in-bud pattern or opacities that are branching opacities, air trapping, and mosaic attenuation. Here we have an example of two different patients with ABPA. You can see that there are multiple opacities that represent mucus plaque within the bronchiectasis, and in this particular case, you can see that there are multiple tubular opacities arising from the hilar region and extending to the periphery, and this is called the finger in glove sign. Finger in glove sign cannot be seen only in the ABPA, but it's very typical from that disease. Other thing that is very typical is to see that the bronchiectasis have mucus plaque that have calcification. In 30% of the cases, the mucus plaque can be calcified, and you can see like a hyperdensity within the involved lung. Here we have another case with dilatation of the bronchi in the perihilar region, mainly on the right side. Just to remind you, there are 5 different types of aspergillosis. ABPA is one of them, but probably the most common type is the aspergilloma, that is the saprophytic aspergillosis, that is the invasion of any pre-existing cavity. For instance, if we have a patient with a previous cavity because of a TB and there is a fungus infection, that is called aspergilloma. Other type of aspergillosis could be airway disease, semi-invasive or chronic necrotizing aspergillosis, or angio-invasive aspergillosis. Traction bronchiectasis is a sign that is seen mainly when you have fibrosis of the lung. So there is a dilatation of the bronchus, not because there is a disease in the bronchus, but there is a disease in the lung that is losing volume and is producing a dilatation of the bronchi. If we are seeing that these traction bronchiectasis are in the upper lungs, that is probably associated with tuberculosis, and if they are in the lower lungs, probably this is the typical appearance of the pulmonary fibrosis. Respect to the pitfall of the bronchiectasis, we have many situations. For instance, artifact respiratory or cardiac motion, inadequate collimation, reversible bronchiectasis that is seen in cases of pneumonia, or something else that is mimicking a dilated bronchus or dilated bronchi, like cystic lung lesions. For example, Langerhans cell histiocytosis or LAM. And let me just show you some example. Here we have a patient with a pulmonary fibrosis and traction bronchiectasis, and you can see that the involvement is mainly in the lower lungs. This is the typical appearance of UIP pattern of fibrosis. Here we have a case of motion, so this lucency that we are seeing surrounding or adjacent to the pulmonary artery is not bronchiectasis but is movement. Here we have a case of a Langerhans disease, and you have multiple irregular and different sizes cystic lesion. This is not bronchiectasis, this is a cystic lung disease, and in this case is a Langerhans disease. In this other case, we have a consolidation area in the right lower lobe with some bronchiectasis, but this is a pneumonia. This is reversible dilatation of the bronchi. This is not called bronchiectasis. Bronchiectasis is irreversible. If it is reversible, we have to call this dilatation of the bronchi. Okay, asthma is another small airway disease that we can see, and what is happening here is that there is a constriction of the airway. There is an inflammation of the mucosa, and there is a mucus. So this disease is very, very old in the time. Actually, Hippocrates was described this disease in 450 BC many years ago. Respect to the clinical finding, we will see dyspnea and wheezing, and sometimes we have coughing. 80%, approximately 80% of the X-rays that we perform in patients with asthma are totally normal. In the other percentage, you can see hyperinflation, flattening of the diaphragm, wall thickening, prominent highlight because there is a pulmonary artery hypertension. But why, if it is very normal, in 80% of the cases we are performing a chest X-ray in cases of asthma? Basically because if we have something in the airway that is compressing the airway, can produce a wheezing. So we have to do a chest X-ray in order to discard any abnormality that is compressing the trachea and the main bronchi like a mediastinal tumor. Okay, I have one of my cases that is my favorite case. That was a lady, 30 years old, treated by asthma during many years, and in one of the chest X-ray we saw endobronchial lesion in the right upper lobe, and there was a carcinoid tumor. So we have to perform this study. Besides, we know that in 80% of the cases probably will be normal. Other thing that we have to discard is the possibility of a pneumonia, bacterial pneumonia, or we can see complications. So here is the typical appearance of the asthmatic X-ray. You have hyperexpansion of the lungs, or you can see some prominent bronchial walls in the perihilar region, or you can see both hyperexpansion and peribronchial thickening that is typically seen in this patient with asthma. Complications, we have a pneumothorax, we have subcutaneous emphysema or pneumomediastinal that we are seeing in this particular case. Okay, if we are performing a CT, the only thing that we will see is some air trapping areas, loosened areas that is representing the small airway disease, and sometimes you can see the wall thickening in the bronchi. Chronic bronchitis is not a radiological diagnosis. It's a clinical diagnosis, and it's based on a cough and expectoration for at least 3 consecutive months during 2 years. So if we are performing X-ray in this patient, probably 50% of them have normal chest X-ray. In the other percentage, we will see peribronchial coughing, or we can see some pulmonary markings in the lung, in the periphery of the lungs, mimicking some interstitial lung disease. Emphysema is another disease that is involving the alveolar space and the area near the airway. What is the definition of emphysema? It's the permanent and abnormal enlargement of the air spaces distal to the terminal bronchiole. So it's involving the secondary lobule, is involving the small airways. And according to the location of this abnormality can be divided in centrilobular, panlobular, paraseptal, and paracikatricial. And here we have different examples. Centrilobular emphysema, the emphysema is raising or is origin in the central portion of the secondary lobule. The rest of the lobule is totally normal, and you can see like a tiny cystic lesion. Sometimes this can be confused with a cystic lung disease. The difference between this and a cystic lung disease is that the cystic lung disease, the cystic lesion have walls. Emphysema has no walls. Other type is the panlobular emphysema, is when all the secondary lobule is involved, and this pattern is seen mainly in the lower lungs. The centrilobular emphysema is mainly seen in the upper lungs and is associated with smoking, and panlobular emphysema is associated with alpha-1 deficiency, antitrypsin deficiencies. Paraseptal emphysema is another type of emphysema that is arising near the interstitial space. So near the interlobular septa, near the subpleural space, and you can see that is mainly seen in the lateral aspect, in the peripheral aspect of the lungs. And finally, we have the parasicatricial emphysema. That is when there is a chronic disease, like in this case, we have a patient with tuberculosis, and you can see multiple emphysema or bullous changes. And also we can see in this case a cavity with a filling defect that is an Aspergillosis. Emphysema is associated with smoking, but there are some other causes that could be drug abuser. For instance, when we have cocaine or heroin drug abuser, the emphysema is seen in the upper lobes. Methadone is seen mainly in the lower lungs. There are other diseases like HIV or pneumocystis jirovecii that is producing emphysema, connective disease, or vasculitis syndrome. Respect to the functional, so the diagnosis is based mainly in functional tests and clinical findings, not in radiographic findings. Why? Because sometimes we have an emphysema with normal volumes, and sometimes we have emphysema with hyperexpansion or a higher volume. Respect to the functional test, we will see a decreased airflow, and there is a decreased diffusing capacity. That is because there is an obstructed disease and not a restricted disease. Respect to the findings in the X-rays, you will see hyperinflation, we have a flattening or depression of the diaphragm, we have increase of the intercostal spaces or retrosternal space. We can see sometimes absence of pulmonary markings in the periphery of the lungs, and sometimes we can see prominent pulmonary arteries in the hilar region. Two different examples of emphysema: hyperexpansion, augmentation of the retrosternal space. Here we have hyperexpansion, we have some flattening of the diaphragm. Sometimes we can see bullous changes or bullous disease not associated with emphysema, and this is called bullous lung disease. And you can see very many types. You have the familial bullous lung disease, you have the vanishing lung disease, Marfan syndrome, as others. And here we have a typical case of multiple bullous changes in the upper lungs, and if you see the rest of the lung is totally normal. So there is no emphysema, just bullous changes. This is not emphysema, this is a bullous lung disease that could be one of the type that I showing here. Familial, the most common type is vanishing lung disease. About complication, we can see infectious processes within the bullous. So here we have a patient with hyperexpansion, multiple bullous changes in the upper lungs, and you can see that in the left side there are multiple air fluid levels. That is because there was an infectious of the multiple bullae in the left hemithorax. And finally, I will talk about a small airway disease or bronchiolitis. That is the disease that is involving the small airways. What is a small airways? It's the airway that is beyond the terminal bronchiole, and there is no cartilage in the walls. That is the characteristic of the small airway disease and the differentiation with the large airway. Respect to the type of bronchiolitis, by far the most common is infectious bronchiolitis. But we have other types that we will discuss briefly. What about the direct signs or findings that you can see in cases of bronchiolitis when you are performing high-resolution CT? The most typical appearance of small airway disease is the presence of the tree-in-bud pattern that is centrilobular nodule with branching lines. You can see also bronchiectasis, bronchiolectasis that are in the peripheral portion of the lung. You can see wall thickening of the bronchiole, and within the indirect sign you have the mosaic attenuation because there is an obstruction of the small airways and there is a distal air trapping area. And on the expiratory films, CT or chest X-ray, you can see air trapping with a more loosened area in the area of the air trapping disease. Infectious bronchiolitis is typically seen mainly in infants and children. If it is seen in adult patients, probably it could be an atypical mycobacteria or could be associated with AIDS, or you can see in both cases. What is the cause or the causes in cases of infant and children? Mainly respiratory syncytial virus, adenovirus, and Haemophilus influenza. And on the CT and high-resolution CT, you can see the trim-bud pattern and centrilobular nodule. Here we have one case of a patient with infectious bronchiectasis. You can see that there is a dilatation of the bronchi, and you can see that there is also thickening of the bronchial wall. And in these two other cases, we can see the branching opacities with centrilobular nodules and dilatation of the bronchi and wall thickening. Other type of disease that is associated with a small airway disease is diffuse panbronchiolitis. And this is typically seen in Asian people, most commonly Japanese or Korean people. This is seen associated with sinusitis, and you can see that the age of the patient are middle-aged, 40, 50, 55 years old. The problem is that the death is 20% within 5 years and 30% within 10 years. And in the high-resolution CT, you will see the same finding as any bronchiolitis. You can see the typical centrilobular nodules, or you can see the branching, you can see bronchiectasis, wall thickening. So you have to have the clinical history in order to do the diagnosis or the final diagnosis. Respiratory bronchiolitis is mainly asymptomatic, but there is a type that is associated with symptoms, and this is called respiratory bronchiolitis associated with interstitial lung disease. And in those cases, you will see the majority of the people that are smokers. This is typically seen in people that is smoking. And probably for many people is the early form of DIP. So respiratory bronchiolitis with interstitial lung disease is the initial or early stage, and the late stage is DIP or desquamative interstitial pneumonitis. In both cases, the age of the patient, very young, 30, 40s, 45, smoking, heavy smoker. And in the high-resolution CT or CT, you can see the trim-bud pattern, centrilobular opacities. You can see ground glass opacities or emphysema, mainly in the upper lobes. Here we have two different cases with respiratory bronchiolitis associated with interstitial lung disease, and you can see ground glass opacity in the lung basis. You can see the mosaic attenuation that is typically seen in cases of a small airway disease. Opacities that could be ground glass opacity. This is probably more normal lung, and you can see also bronchiectasis in the central portion of the airway. Hypersensitivity pneumonitis, or HP, is called or has been called extrinsic allergic alveolitis. And this was described initially in farmers and bird breeders. But today we have multiple microbial and organic and inorganic dust that is producing this disease. There are 4 different histological features. Initially, we have a cellular bronchiolitis that is an infectious, very acute infectious process. Then we have a chronic inflammation in the interstitium. Then we have the formation of granuloma, and finally we can see giant cells in alveolar space and in the interstitium. There are 3 forms. The most common types are the subacute and chronic, and acute is practically not seen because it's very, very uncommon, because it's producing after 4 to 6 hours after the exposure. So this practically is not very well seen, because it's not very common, because normally when the patient is coming to us to see the chest X-ray, normally the infection or the allergic process has finished. What could happen in this page, in this kind of HP? Normally we have diffuse ground glass opacity that can mimic pulmonary edema or hemorrhage. Actually here we have one of the patients with acute HP, and you can see ground glass opacity mainly in the perihilar region, and this can mimic a pulmonary edema or hemorrhage. Here we have some centrilobular nodule that is not very common, because the most common pattern is the presence of ground glass opacities. Subacute HP is the most common type that we are seeing. We can see that there are some centrilobular nodules. We can see that there are some ground glass opacities in the bilateral lungs, any portion of the lung, upper lung, lower lungs. You can see more diffuse or you can see patchy areas of ground glass opacity. And in 10% of the cases, you can see thin wall cysts. Here is the typical appearance of the subacute HP, that is the presence of the centrilobular nodule. This centrilobular nodule that are seen here is typically seen in this kind of patient, and also you can see air trapping disease in some patients. And finally, the head cheese sign is one of the characteristic signs that we can see in HP, and there is a combination of consolidation area, ground glass opacity, air trapping disease, and normal lung. And this is called the head cheese sign, that is not typically seen or only seen in this patient because, or in this kind of disease, because can be seen in DIP, respiratory bronchiolitis with interstitial lung disease, mycoplasma pneumonia, or sarcoidosis. And finally, the chronic HP that is typically seen with fibrotic changes. So you will see reticulation, traction bronchiectasis, honeycombing, loss of volume, and this is the typical appearance of the chronic HP. Multiple cystic lesion, bronchiectasis, interstitial lung disease, ground glass opacity, mainly in the lung basis. Follicular bronchiolitis is another type of airways, small airway disease. This is a hyperplasia of the bronchus-associated lymph tissue. And there is a deposit of these lymph follicles in the interstitium adjacent to the bronchi and bronchioles, and is also seen in the interlobular septa and near the pleural. This is typically associated with rheumatoid arthritis or Sjögren, so you can do the diagnosis of follicular bronchiolitis because of the history of the patient. Respect to the imaging finding, you will see areas of ground glass opacity, air trapping disease, trim bud pattern, that is branching opacity with central lobular nodules or peribronchial nodules. This is a case that was taken from this publication, and you can see that there are multiple nodularities, trim bud pattern, bronchial thickening, more nodular opacity, here a bigger nodule, and this is the typical appearance of this disease. Obviously, the history of the patient is very important to do the diagnosis. Constrictive bronchiolitis, or BO, is a non-specific reaction, and is characterized by an inflammatory process within the terminal and respiratory bronchiole with narrowing of the lumen. So, in these patients, you will see air trapping disease associated with this abnormality, that is the obstruction of the small airway. You can see also in rare cases trim bud pattern or reticular opacities. Respect to the etiology of the BO could be idiopathic or could be secondary to an infectious process, mainly viral or bacterial infections, can be seen in connective tissue disease, can be in cases of toxic fume, in cases of drugs, especially in patients with rheumatoid arthritis and treated with gall, or could be secondary to a transplant. Here we have a case with a high-resolution CT during inspiration, during expiration. And you can recognize that this is an expiratory film because there is a bowing anterior displacement of the posterior trachea. So the membrane posteriorly, normally when is in inspiratory phase, is convex. Here is bowing anteriorly. And you can see that here there is a pretty normal lung with some areas of suspicious of air trapping disease, but when you see the expiratory film, there is a large zone here in the left upper lobe and left lower lobe also that is secondary to the BO. In this patient was a post-infectious BO. Finally, we have the Swyer-James syndrome, or Maglio syndrome, as you prefer. This is mainly seen in childhood, secondary to a viral infectious process. Okay? And you will see that there is a hyperlucent lung respect to the other, and sometimes in the X-ray you can see that the hilar region is smaller in size. You can see that the lung involved is normal in volume or could be hyperexpanded, but is more loosened than the contralateral normal size. Here we have the typical appearance of this Swyer-James syndrome. You have a normal right lung. We have a very hyperlucent left lung, and you can see that the left hilum is very small, smaller than the contralateral. So the problem is in this area, and you can see that here the vascularity is less visible than on the other side. So this is the typical appearance of the Swyer-James or Maglio syndrome. And finally, as a conclusion, if we have a bronchial disease and we are talking about the findings in the high-resolution CT, we have 4 different findings. Tree-in-bud pattern, decreased lung density or hyperlucency, centrilobular nodule, or ground glass opacities. If we have tree-in-bud pattern, probably the most common causes could be any infectious process, TB, bacterial, viral, ABPA, some cases of asthma. If you have a hyperlucency of the lungs, we have to check the Swyer-James syndrome and check if there was a history of viral infections in the childhood. You can see the decreased lung density in cases of PO and also in cases of respiratory bronchiolitis and asthma. If you have a centrilobular nodule, mainly the diagnosis is HP, but can be seen in infectious bronchiolitis and also can be seen in respiratory bronchiolitis with interstitial lung disease. Which is the difference between this and this? In respiratory bronchiolitis, interstitial lung disease, the centrilobular nodules are in the upper lobes. In HP, they are more diffuse, upper and lower lungs. Finally, if we have ground glass opacities or consolidation areas or both, probably the most typical diagnosis could be organizing pneumonia. Could be unknown of etiology and is called cryptogenic organizing, or could be a secondary organizing pneumonia. Finally, we have collagenal vascular disease and less frequently infectious bronchiolitis. Okay, that's it, and thank you very much.